Hello everyone, welcome back, and you are watching your medicine channel which makes medicine simple, MMS. As in the previous lecture, we have discussed about the epidemiology, etiology and the environmental factors which affect rheumatoid arthritis. Today we will talk about the clinical and the articular symptoms of rheumatoid arthritis. As we have one rheumatoid factor which is an antibody against the antibody, an IgM against the Fc portion of IgG. Also, your rheumatoid arthritis patient will have elevated levels of ESR and CRP, the inflammatory markers, and also hepcidin, the acute phase reactant. Since we know that rheumatoid arthritis is an autoimmune, chronic, symmetric, systemic inflammatory type of arthritis, means your patient might have both articular and extra-articular features. So in this lecture, we will talk in detail about the articular features and we will discuss the extra-articular features in our next lecture. So also here you can see the picture of this beautiful lady with rheumatoid arthritis. Her name is Simran and she is my imaginary patient. So you can observe here that she is in severe pain, right? She is about to cry. So I'll wish that God will help this beautiful soul to stand with this unbearable pain of irreversible and non-reducible joint deformities of rheumatoid arthritis. So before we proceed to articular features, let's recap something important. As also we discussed in our previous lecture that rheumatoid arthritis is an autoimmune, chronic, systemic, inflammatory disease which affects your small joints and symmetrically. Also this is common in females. The female to male ratio is 3:1. Also the patient with rheumatoid arthritis might have both articular and extra-articular features because this is the systemic inflammatory arthritis. Okay. Since rheumatoid arthritis is an autoimmune, chronic, symmetric, systemic, inflammatory disease. Inflammatory means your patient will be there with the cardinal signs of inflammation, such as redness, swelling, pain, hotness, and disability, loss of function, which is worse in the morning and improve as the day passes with physical activity. Also, since it's inflammatory, mean your patient will come to you with the elevated levels of ESR and CRP. Whereas in the osteoarthritis, which is an asymmetric, non-inflammatory arthritis, means your patient will not have the cardinal signs of inflammation and the elevated levels of ESR and CRP. Unlike rheumatoid arthritis, in osteoarthritis, the stiffness and pain is worse in the evening. Now let's talk about the clinical features of rheumatoid arthritis. So the symptoms of RA typically results from the inflammation of joints, tendons and bursae. As we already know that rheumatoid arthritis is an autoimmune, chronic, systemic inflammatory type of arthritis which affects your small joints involving your hands, feet and your wrist. Please take a note that wrist is the most commonly involved joint in rheumatoid arthritis, which is involving the MCP metacarpophalangeal joint and PIP proximal interphalangeal joint. Though the DIP distal interphalangeal joint is spared in rheumatoid arthritis, but it may affect if patient is having coexisting osteoarthritis. Also joint stiffness and pain, which is worse in the morning and improve as the day passes with physical activity. In rheumatoid arthritis, stiffness predominant over the pain which is lasting for more than 1 hour. Though both stiffness and pain improve with the use in rheumatoid arthritis. Whereas in osteoarthritis, pain predominant over the stiffness and which is worse in the evening and lasting for less than 30 minutes. Like rheumatoid arthritis, in osteoarthritis also, stiffness improve with the use whereas pain worsen with the use. Right? Also as we know that rheumatoid arthritis is an inflammatory disease, which means your patient will come to you with the elevated levels of ESR and CRP, the inflammatory markers. Also, as we know that this is the symmetric polyarticular arthritis, which means affecting both the wrist equally and involving more than 5 joints. Sometimes, when we cannot classify it as a specified rheumatologic disorder, right? But patient is having like joint swelling, pain and stiffness, then we classify that rheumatoid disorder as an undifferentiated inflammatory arthritis. Also, as we know that rheumatoid arthritis patient, because this is the inflammatory disease, so patient will present to you with the cardinal signs of inflammation like redness, swelling, pain, hotness and loss of function, disability, along with the constitutional symptoms like fatigue, weakness, weight loss. Now let's talk about the joint deformities in one RA patient. So the joint deformities in rheumatoid arthritis patient are non-reducible and irreversible, means you can't go back. So let's begin with Botonia Deformity. This is because of the flexion of PIP, the proximal interphalangeal joint, and hyperextension of DIP, distal interphalangeal joint. Please take a note that this is hyperextension, not only extension, and hyperextension which is pathologic, right? Swan-neck deformity, which is just opposite of Botonia deformity, right? Like hyperextension of PIP, the proximal interphalangeal joint, and the flexion of DIP. So this is swan-neck deformity, right? You can see here that the finger looks like a neck of swan, okay? Z-line deformity, also known as Zeta thumb. This is because of the fixed flexion and subluxation of the first MCP, metacarpophalangeal, which is here, joint with the hyperextension of the first interphalangeal joint, right? This is here. So the thumb looks like one letter Z, okay? So this is interphalangeal, right? Only thumb have the interphalangeal joint. Ulnar deviation. This is because of the subluxation of the MCP joint, right? So please take a note that this deviation is on this level, on the level of metacarpophalangeal joint, not here, okay? Then flexor tendon tenosynovitis. So this is the hallmark of rheumatoid arthritis, and patient comes to you with a decreased range of motion, reduced grip strength of your wrist, and the fingers looks like a trigger, right? So known as trigger fingers. Now let's talk about the piano key movement, also known as piano key sign, piano keyboard sign, and piano key deformity. Though with the name, it seems like something romantic, but that is not the case. Because of the inflammation of ulnar styloid and tenosynovitis of the extensor carpi ulnaris muscle, which attaches your proximal radius with your distal ulna somewhere here, okay? So because of that, there is distal radio-ulnar instability, and because of the subluxation of the distal ulna, the ulnar styloid is unstable, and then it moves like back and forth like a piano key. So this is all about the upper extremity deformities in rheumatoid arthritis patient. Now we will talk about the lower extremity. So pes plano valgus, flat feet. Because of the involvement of MTP, metatarsophalangeal joint, which is the early feature, and then the chronic inflammation of ankle and mid-tarsal region, which comes later and leads to pes plano valgus, the flat feet. You can see this is the normal arch of your feet, and this is the flat feet because of the pes plano valgus, flat feet. Now in the last, we will talk about the neck, the cervical spine involvement in rheumatoid arthritis patient. So this is atlantoaxial subluxation because of the involvement of the cervical spine with the progressive instability of C1 on C2, right? So atlantoaxial subluxation is a serious but infrequent complication of rheumatoid arthritis that causes neurological symptoms and the signs of spinal cord compression, including like sudden or gradual onset of neck pain or post-auricular pain, head tilt, ataxia, limb weakness, loss of bowel and bladder control, and increased tendon reflexes. So thank you so much for watching, and please do subscribe the channel to get all latest videos like this, and also help this beautiful imaginary patient Simran to reach and teach more and more people like her about this nasty disease, rheumatoid arthritis. Stay safe, stay happy, study a lot. Thank you so much, guys.